Hey everybody, this is Dr. Paul Thomas with Startup DPC, and I have a wonderful guest today. This is Dr. Ashley Walker, and she's a pediatric resident at Hurley Medical Center in Flint, Michigan. So one of my neighbors. I'm really excited to have you on the show to talk about what it's like being a resident, why you're attracted to DPC, and logistically how we can help you get there. So thanks for coming on.
Yeah, perfect. Thank you for having me. I appreciate your time. I definitely have a lot of questions as I've been reading, trying to kind of figure out where I'm going to go with my practice. And so I appreciate your insight in advance.
Oh, you're welcome. Happy to do it. So tell me where you're at. What year are you in your residency right now?
Yeah, perfect. So I'm a second year in pediatric residency in the Flint area, planning to probably stay in the Flint area to do primary care when I graduate in 21.
Oh, wow. 2021.
I know.
That's awesome. Well, that's great. And you have some other interesting experience. You graduated from med school in 2013. You worked in the military in kind of like a family medicine office. So you have some experience as a physician and I guess what would be the term for that? Like a military physician?
Yeah, general practitioner essentially as a physician. Yeah.
That's awesome.
Yeah.
So it's kind of interesting that you're coming at this with a unique perspective. You've probably seen like how the military operates, their chain of command operations, day-to-day operations, and then you're seeing how a larger hospital system operates, and now you're trying to navigate this direct care system as well. So it's kind of interesting.
Absolutely. Yeah. And it definitely has been a couple different systems. I went through my medical training in med school in Michigan as well on the civilian side. And then the military medical system is a lot more like maybe a socialized kind of medicine where everything is paid for, everything is covered. But I would say with really good access to care. So I've kind of observed over the years and taken bits and pieces of what I like and what I don't like. And I'm trying to put that all together to be a formal practice, I guess, long term.
Yeah, that's one of the values about this direct care model is that, each doctor is unique and we can bring our own unique perspectives and we focus on the things that are important to us and for our patients. And so you end up with these really innovative, interesting, unique practices across the country.
Right,
Cool.
right, absolutely.
I'm excited to see what you developed.
Yeah.
Which brings me to the first big question, which is like, why the hell do you want to start a direct care practice?
Yeah, exactly. And I've mentioned to you through emails. I read your book. It was a nice quick read, and I remember reading just the first few paragraphs where you kind of talk about being ready to just kind of walk away from everything, take a risk, and kind of jump all in. And I very much sort of identified with that. In that,
awesome.
I'm really ready to kind of just go out and really do something that is going to allow me to take care of my patients well. I feel like even just in the few years I've been practicing and seeing different settings, I feel like as physicians, a lot of times we're sort of losing control of being able to do what we feel is right for our patients and what our patients feel like they need for themselves.
Right.
And so I think that's sort of the beauty of this model that really has drawn me to it and definitely made me interested in trying to replicate it.
Yeah, I think that's a big theme there. And I think if I could put a word on that, that'd be like physician autonomy and
absolutely,
being able to operate in the best interest of your patients. So yeah, I think that's just a really common theme, and welcome to the tribe. That's your thing, then you'll be great with the rest of us.
Absolutely. Yeah.
All right. And then the second big thing is like, how can I help you get there? Like, what are the questions that you have to, make this move, make this transition to DPC?
Yeah, so I have a handful of questions, and again, I appreciate your time in advance. So the first one is just, as I'm sort of researching this and reading about it, and I'm seeing family practice, and I haven't really seen just a purely pediatrics practice. So I'm wondering if, from your experience, if you think that doing this as purely pediatrics is something that would be feasible, but also, what sort of extra considerations or challenges might you expect that I should be anticipating that I might not be thinking about at this point?
Okay, that's a great question. And usually a lot of family docs do take care of pediatric patients, and the price ranges are variable. In our practice, I think we do a very low charge at $10 a month for kids, which would not be sustainable for somebody who's doing a panel full of kids. So there are other doctors, like I just heard about Nova in Michigan. They're in Western Michigan, Grand Rapids. They're charging $29 a month for
Okay.
children and having like a bundled family plan. So, and then there's others who are doing solely pediatrics and it ranges from like a more of a concierge niche practice that focus on lactation and really high touch to more traditional direct care where you have a typical membership model for primary care for kids. So I think it's totally feasible. You just have to set your price point or price points at a reasonable level for the value that you can offer patients and families.
Okay. As far as finding some sort of a niche.
Right. And I think, it might be $50 or it might be $70. And it just depends on how much you're able to provide to pediatric patients. Now, I'm going to pull up Google here. And I think his name is Dr. Brian Hill. Brian Hill at Gold Standard Pediatrics.
Gold Standard. Okay, great.
Let's just pull up his website here. Okay, so this is their, Gold Standard Pediatrics. Here are their membership price points.
So they do have it higher for birth because you have like visits every 2 months or whatever for the first year. Okay.
So, this would be a pretty standard, pretty typical, price structure. And it's not unreasonable if you're a parent and you know that in the first 2 years, you're going to have overnight issues, you're going to have multiple visits in your first few months.
Absolutely.
Totally a reasonable way to go in terms of, your pricing structure. And so if you're averaging $50 per member per month, you can start to imagine like if you had 500 patients, you could get $25,000 a month in revenue.
Okay.
$300,000 a year in revenue, right? So then your overhead might be $10,000 a month or $12,000 a month. So that would be, either $120,000 in overhead or $60,000 in overhead. So you can start to see where you might need to be in terms of your numbers. And patient panel specifically and your price points. So, if you had a higher price point and your average was $70 per member per month, then maybe you only need 400 patients to have a thriving DPC practice.
Right. Okay.
I'm glad I remembered that. I met
that's really helpful.
I met Dr. Brian Hill at the last, I believe it was the DPC summit a couple of years ago.
Nice, and I have to look out for those. That sounds really interesting too.
Yeah, so there's one in November that's going to be that's in Florida. That's the Docs for Patient Care Foundation. They have their DPC nuts and bolts. That's a great conference. And then every summer, usually June or July, there's a DPC summit, and that's hosted by the AAFP, American Academy of Family Physicians. And they have great content and everything like that. Well, those are great. And in addition, in April, there's the Hint Health Summit. That's geared more towards larger DPC practices. And it's geared less towards solo independent DPC docs. But also there's good content and good connections to be made with people there. Okay, very cool. Good. Yep. All right. What's next on the question? For the next one? Yeah. So the next one, again, kind of comes from reading your book. So you mentioned, because a lot of times you think of this model as being sort of similar to concierge medicine as far as just when you quickly kind of try to explain to people what it is. One of the things you mentioned, though, that kind of surprised me in the book was that, and you're out of Detroit area, right? Yeah, that's correct. We're in Southwest Detroit. Yeah, perfect. So it was sort of more of an equitable way to practice medicine, which I was pretty interested in because I do work with the Flint population with a lot of Medicaid patients. And I was just curious to hear sort of how that worked or how you think that might apply to sort of that Flint population that I'm working with. Yeah, I think, anytime you're working in an urban underserved area, you're giving back. And, we are in Southwest Detroit. The majority of our patients are Detroiters, but we do draw on people from the suburbs because we offer a really high value, quality primary care service. And it's kind of nice to see the guy driving in from Birmingham, right after the the family from Detroit and
Yes.
the woman from Taylor, or the mom from Grosse Pointe, or the college kid at Wayne State or CBS. So it's kind of nice to have that mixing of different people of different income levels and everything like that. Personally, I like that. I think I say that I want to take care of anybody with an income can afford our memberships. That's the way we structure it. So, if you think of that in that context, you're doing good work and it feels good going into work. That being said, you don't have to. You can charge whatever you want. You can make as much or as little money as you want, and you're doing something really good by being a primary care physician in an urban setting anyways. So you're giving people another option to take advantage of your services.
Yep, absolutely.
So for me, it was important, like growing up, in Detroit and Grosse Pointe, and seeing the divide between the two, it was important to kind of like give back in this tangible way.
Yeah.
Achieve that goal in, 3 years, where we've created this membership service that's become a model, and it's exciting. So it's kind of exciting from people like you who are like, yes, I want to do this in Flint.
Yeah.
And if people from outside of Michigan are watching, they're unfamiliar with Flint, just a little background. It's an economically depressed area because they used to host GM and a lot of auto workers. And when the manufacturing dried up and those jobs went away, it became an economically depressed area, segregated in that people with money would move out. And those are mostly whiter folks leaving, mostly African-American folks in the city with a lack of resources and jobs. So, and it led to something like the Flint water crisis. It's been a national story and a national tragedy, in my opinion. So,
absolutely.
If you're going there to serve pediatric patients, I mean, that's an amazing.
It's an awesome place to work. It really is. I love it. Yeah. Okay. And then sort of, I'm going to skip questions here, because sort of along those lines, I'm wondering, you mentioned anyone with an income, and I know sort of one of the foundations of direct primary care is that you don't charge insurance companies, and you don't look for that sort of income. The only question I have surrounding that, though, is for people who are employed, I feel like more and more we're seeing people with like health savings accounts. Is that something that you feel like could be tapped? Because I mean, I've seen them use that for mattresses with back pain kind of things.
Isn't that crazy?
Is that something you could tap at all, or is that still not something?
So direct primary care doctors are accepting payment via HSA. This is a gray area in the tax code. As it's written, it would constitute as a health plan, which would make it illegal to take HSA payments. But the practice that I've observed is that some doctors choose to take HSA payments, and we take HSA payments in our practice. We haven't had an issue with it. We write a letter to the company that administers HSA funds annually, if necessary. It's only happened like 3 times that they request documentation. But my argument is that I'm providing a primary care service to your member for their HSA funds, and it's not an abuse of funds. Other people have segmented their billing. So let's say you bill out $210 for a visit in a 3-month period, and your membership rate is $70 a month. I don't think that's necessary, but I've seen people do it like that.
Playing the game.
Around. Yes.
Yeah. And it almost makes you think that maybe we should be advocating for more sort of legislative changes as far as what the tax code says in the first place to allow for something like this.
Right. So there are doctors doing that.
Really?
Notably, Dr. Lee Gross, who is hosting the DPC Nuts and Bolts. They do a lot of legislative work. There's a group called DPC Action that is trying to work on the legislative angle, specifically fixing the language in the tax code to allow folks to use their HSAs without any legal gray areas.
Right. Yeah, absolutely. Okay. That answers that question very well, actually. Thank you.
Oh, you're welcome.
Okay.
But my final advice would be talk to your lawyer and talk to your accountant to, and if, follow their advice, because I cannot give you financial advice.
No, it helps just to kind of know what I should really be looking into and thinking about.
Great.
Absolutely. Okay. Perfect. So shifting gears a little bit, one of the things that is important to me, I have little kids at home. I think a lot of us that go into primary care, family practice, pediatrics, work-life balance is sort of important to us. But I also know that, again, one of the sort of underlying foundational pieces of the direct primary care model is that you have to have really good accessibility for your patients. That's sort of part of what the marketing is that you're accessible. How have you found ways in your own practice to kind of balance and schedule your time so that you are there for your patients and have that accessibility for them, but then also still are sort of protecting your own personal time and your own personal life?
Yeah, that's a great question. And you're basically setting the tone with your patients and telling them how you want to be treated with every interaction. So if you are answering text messages at 10 p.m. for med refills, you're going to get more text messages at 10 p.m. for med refills.
Right, absolutely.
So I have, in a way, trained my patients on how to treat me and respect my time. And they know that if there's an emergency or an urgent problem, they should call me right away. But if they need a refill, text me or email me during the day. And if they do email me after hours for stuff like that, I just wait until the morning at around 8 or 8:30 and respond to it. And that sets up a nice dynamic of, okay, Dr. Paul's going to respond to me. I get a faster response if I text him during the day, and he's slower if I text him at night.
Absolutely.
Right. So that's one way to work it. The other way is like, some days I don't have patients scheduled in the morning. And if my wife is off from work, we'll hang out at home and relax and spend some quality time together. My Saturdays and Sundays are really important for me to spend with my family. So, that's important. I don't see patients on Saturdays or Sundays unless it's an urgent thing. Over the last 3 years of doing this, I've probably come into my practice maybe 6 or 7 times. It's really to sew up a laceration or stop a bleed or something urgent like that, where I can save somebody, $1,000 from going to the urgent care emergency department. So that's when I'll come in, because I want the service to be valuable, but I also want my time to be respected. And it takes some time to figure that out, but eventually people get it. And I come in early sometimes, let's say 8 or 8:30, to see somebody who works 9 to 5, especially
which is awesome.
They can't get away from their work responsibilities. So I'm happy to do that to help them meet their health goals and meet their financial goals. And sometimes I'll stay for a 5 or a 5:30 appointment, but I'll only do that if I know my wife is working later that evening. So, it's kind of like a give and take where I work with my patients as best as I can.
Yeah, absolutely. And then what do you think the utility would be as far as, or the, I guess, cost benefit balance of using some sort of like an answering system or something like that, or a nurse advice line or anything like that? Have you used that, or do you have any?
I haven't. I'm pretty transparent with my patients. Everybody has my cell phone number, and I just prefer it that way because that's my style and that's what I like. But I'm sure you could figure out an answering service. I haven't really talked to many doctors who say, oh, I use this answering service and it's a lifesaver, because a lot of this stuff, frankly, if somebody texts me, it's a preferred method of communication. So I really drive people towards texting me. That way I can instantaneously take a look at my phone and decide whether it's urgent or not. And if I need to call them, I'll call them right back.
Yeah, and then you were triaging instead of trusting somebody else to be triaging for you and giving advice for you. Yeah.
Exactly.
Okay, that makes sense. Yeah. Okay. Okay. I think that answers that question.
What's up next?
The next one, let's see. I have, I think, 2 or 3 more. As far as negotiating prices, so I know you talked about, making sure that when you accept a new patient, that you are looking at what their medication list is and negotiating prices to see, as far as having your own sort of stock of wholesale medications to offer, and then also negotiating with labs or with radiology centers. How often do you sort of go through renegotiations, or do they have generally like a set price list? How do you do that?
Yeah, for the wholesale medications, there's a set price list. We buy ours through Andameds out of Florida, and they pay,
Okay.
we pay a set price, their list price for that. And
Okay.
you can get into a group purchasing organization or GPO to get a
Okay.
slightly better rate, and I can
Okay.
extend that to you. That's,
Cool.
that's pretty standard. A lot of the DPC docs have that GPO.
That's great.
The other thing is the lab. Let's
Mhm.
do imaging next. Usually with imaging in your neighborhood, there's regional medical imaging. That's who I
Right.
use for my imaging.
Yep.
And they're a standalone service and they're
Yep.
headquartered in Flint. And the
Yep.
doctors there are amazing. And you can call
Yeah.
them, talk to them about the images. And they just have a cash list price
Great.
that they can send you.
Easy.
Yeah, super
Yeah.
easy. So two really easy ones. The harder one are labs. So
Okay.
you kind of have to play games with Quest and LabCorp or whomever, but
Yeah.
those are
That's what we have out here.
and you have to ask for better pricing and better pricing.
Yeah.
And
Hmm.
this price seems high. Can we get better pricing? And then
Right.
send you my list. You can ask other DPC docs across the country what
Okay.
kind of prices they're getting. And then
Hmm.
you can take it back to them and say, listen, Dr. Paul down the street's getting this. Why am I getting
Yeah.
it's a game. You got to find the
Yeah.
right person. You got to find the right rep. I can send
Okay.
their contact
Okay.
info, make it
Okay.
easy on you as the date gets closer. But you want to start doing this like, you want to get those contracts set up, 3 months before you start. And then every month,
Yeah.
week, send them a note. Hey, I want to get better pricing on this.
Yeah.
And eventually you'll find the right person. You'll get the right pricing.
Yeah. And how much do you utilize like point of care testing in your practice?
Not much. Just
Really?
because I get overnight results for like a
Okay.
hemoglobin A1C or a lipid panel. It's
Yeah.
like I do point of care blood sugar testing, and
Yeah.
if I do a pap test or if I do a vaginal exam where somebody has BV, I have the
Yeah.
microscope in the office.
Right. Okay.
Just use that. Let's see, occult blood testing I can do in my office.
Okay.
I have had rapid strep and rapid flu tests. Those are like $15-$20 a piece.
Okay.
You kind of have to weigh risk, cost benefit on that.
Mm-hmm. Right.
Versus your clinical gestalt.
Yeah. Absolutely.
So, those are the basic point of care testing. I also have a PFT and EKG machine.
You do? Okay.
There are PFTs. The PFT machine was $700. I was looking over there. It's sitting right over there.
Yeah.
EKG machine was $1,700.
Okay.
So.
Yeah. Yeah. So that's helpful to know kind of what.
Yeah, that's like
sources.
That's like brand new. You're buying that from.
Yeah.
Whichever company you're buying it from, and that's a cost.
Okay. 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 And then let's see here. This is a good one. One of the strong factors that as I'm talking to physicians out in practice, that's really pushing, I feel like, especially primary care physicians more toward large hospital systems and group practices and things like that is malpractice insurance. Can you talk to me a little bit about how people do malpractice insurance and make it still stay in the black and not go into the red?
Yeah, I don't think that's your biggest issue at all. I think that's a misconception.
Okay.
So my biggest line items in my budget are staffing, like for rent, square footage, and then malpractice, and then my EMR. So right now I'm renting this this beautiful one-room office that I'm currently in right now.
Great.
I pay $600 a month for this.
Okay. Nice.
And then I have an employee staff person.
Mm-hmm.
I pay them $17.50 an hour.
Okay.
My medical assistant.
Yep.
So that's like, $3,000 a month. Right?
Okay.
And then my malpractice insurance is $450 a month.
Okay. So it's just a little bit less than what you're paying for your space.
Yeah.
Okay.
And then my EMR, I use an EMR. Typically, they're in the $300 to $600 range monthly for your EMR.
Okay.
I order about $1,500 worth of meds each month, sometimes $1,000 worth of meds each month. Mm-hmm. And I run about $1,500 worth of lab work each month.
Okay.
So there are bigger items in your budget than malpractice insurance. And some malpractice insurers, like the Cunningham Group, offering reduced rates for malpractice insurance based on being a DPC doctor, having more time with your patients and fewer patients.
Yeah.
So the actuaries or the people who are counting up the numbers on this are actually finding it's less expensive to insure DPC docs. So that's
I'm sure. Yeah, that makes sense. Okay, that's a good thing to look into. That actually makes me feel a little bit better. And you actually sort of started to answer, I think, my last question that I have here is staffing, because it was kind of funny reading in your book about how when you first started you were doing home visits because you didn't have a space.
Yeah,
I think that's great. I love it. But as your practice has kind of grown and you're gaining more patients and probably have a higher workload from that standpoint, what sort of roles and staffing do you feel like is helpful for you to have?
Yeah. So, 3 years in, or like 2 years, 10 months in, I hired my first staff person. Now, his name's Chris. He's our medical assistant. He gives vaccines. He takes vital signs. He enters information to the electronic medical record. He does our inventory. He will call different vendors and get different prices for things. He'll make sure that the lab pickup is set and the, pathology labs are sent out and everything's packaged appropriately. Basic tasks. And then, as we work together, I hope to train him to be able to do more and more and more stuff.
Right.
That we can do, really just focus on taking care of our patients more and more.
Yeah.
So right now, I'm working, and then Dr. Raquel's here. Dr. Raquel started in July, October, we're in mid-October right now. She's up to she's at 86 patients today.
Wow.
Which is amazing. Good. So in July, August, September, October, she's halfway through October at 86. So 3.5 months, 86 patients, which is great.
Awesome. Yeah, that's huge.
So, Chris is now doing the basic contract. We have a contract that's like 10, 12 pages. So Chris is going through the contract with our new enrollees so that they walk into Dr. Raquel's office just to take care of the medicine part. Nice.
Okay.
Versus like when I started, I was doing everything. So I was doing the contract, scanning it in and emailing it to the patient. So, there are tasks that you can offload. It wasn't unmanageable, but it definitely tied up more of my time than I wanted to have tied up in like the paperwork of it.
Yeah. Yeah, which, absolutely.
In this model, I'm doing more than half of my time taking care of my patients, less than half my time doing paperwork. Whereas in the other system, it's the other way around.
Yeah, absolutely. I think that's fantastic.
Can write my notes in under 5 minutes because it's writing a SOAP note.
Right, exactly. Especially with an EMR and kind of working out your templates and stuff. That's awesome.
Yep.
Good. I think I'm out of specific questions.
Beautiful. I think you're the quintessential medical resident who is really interested, wants to know how, and wants to kind of like visualize in your brain how to make this work logistically.
Right.
The other things that I talk about, and I'm working on my second book right now, I'm wrapping it up, and it goes into like step by step how to do all this stuff. And I'm doing these conversations in like bi-directional. Hopefully this has been great for you to learn some stuff.
It's been so helpful. Yeah.
These are the gaps that I want to address in this book and then also on the website, because I get these questions all the time. So if I can guide other doctors or residents to this information, it's going to make their lives easier. And then
absolutely.
Okay. That aside, there are some other things like branding and marketing, and Facebook and Google and search engine optimization. These are the things that as you go, you'll have to learn about to be successful. So hopefully that will be out in the next, month or so.
Great. I'll watch for it.
Yeah.
Okay.
Well, thank you for your time. Thank you for the great questions. And I wish you really good luck. Let's stay in touch and send me some emails. We're going to end the show here, but we'll talk after the break too. All right, everybody. Thanks so much for watching and have a great day.